The talk here goes through a few things that we should know about bariatric surgery. You know, this slides are based more towards complications of bariatric surgery, but I think you can't really talk about the complications until you talk about bariatric surgery itself. So the first thing is why do we deal with this? Well, obesity, as we all know, is on the rise. Obesity is defined as BMI over 30. And when you look at how you treat obesity, there are only really three ways. It's lifestyle changes with diet and exercise, weight loss drugs, and weight loss surgery, and that's it. There's nothing else. If anyone has any ideas on other ways to treat obesity, don't talk about it. See me afterwards, and I will call Oprah myself. Right? But this is it: diet and exercise, weight loss drugs, weight loss surgery. The problem is diet and exercise is not wildly successful. 5% will lose 5 to 10 pounds when you look 5 years later. I'm not talking about when you starve yourself for 2 weeks and lose a bunch of weight. I'm talking about sustainable stuff. What your weight does 5 years later. Because if you plan to live longer than a couple of weeks, your weight loss should not be a 2-week weight loss plan, right? With weight loss drugs, folks will lose about 5 BMI points. It's not sufficient for folks that have a BMI over 35, especially when they have comorbid disease like diabetes, high blood pressure, sleep apnea, things like that. As we talked about, obesity is on the rise. In 2000, you could see how you had a lot of blue in the country, and now you have more red, and the red denotes over 30% incidence of obesity. Now this is old, this is 2010. Sadly, the problem hasn't gotten better, it's gotten significantly worse. So the color now will be almost all red. So bariatric surgery, what is it? What are we talking about? You know, bariatric surgery gets portioned out differently depending on kind of your approach. Some people talk about it in terms of restrictive versus malabsorptive procedures, and others will talk about it, you know, like credentialing bodies will talk about it in terms of stapling versus non-stapling procedures, right? I think it's reasonable to look at it stapling versus non-stapling because the stapling adds an added layer of complexity and increased risk. So your stapling procedures are the sleeve gastrectomy, gastric bypass, duodenal switch, which is not altogether common. And your non-stapling procedures, your adjustable gastric banding. And so really briefly talking about each one, how you do it. The gastric band involves taking a plastic tube basically and wrapping it around the proximal stomach, the upper part of the stomach. To prevent it from sliding back down, you have to flap the stomach over the band, kind of to hold it in place and suture it. And that's why you always have this flap over the band. The tubing is then connected to a port that's put right under the skin. The idea behind this is that you can access this port, put saline into the tubing, and it blows up a balloon within this band that tightens like a sphincter around the proximal stomach. That way, the theory is that patients eat food, the food fills up the proximal stomach here, gives you the feeling of satiety so you're not hungry anymore, and then slowly, depending on the tightness of the band, the food can progress on to the rest of the stomach. So that's how it's done. The sleeve gastrectomy involves removing a portion of the stomach. You staple along the greater curvature of the stomach and you remove this section of the stomach. People always ask, how much stomach are you going to take out? Well, it depends. It depends on how big your stomach is. I think the more important question is always how much stomach are you leaving behind, and that's dependent on the size of the bougie you put in. The bougie is a plastic tubing you put into the stomach and into the duodenum, and then you staple along the bougie, and it comes in different sizes. So you can imagine if you have a very small, slender stomach, I'm still putting the same bougie in. If you have a really wide stomach that goes all the way out, I'm still putting in a XYZ size bougie. The other thing is, depending on how tall you are and just how your anatomy is, the length from the hiatus here to the pylorus here is going to be variable. If you have a really short stomach that's really wide across, I'm still putting in the same bougie, removing whatever's left of the stomach. But that's how the operation is done. The roux-en-y gastric bypass, now we're getting into more complex stuff because we're working on the intestine. Gastric bypass, here's your stomach, here's the intestine, drawn in a cartoon fashion. The first thing you do is divide the stomach up top here and divide the intestine down here, right? So those are, you divided the stomach, you divided the intestine. When you look at this kind of grayed out area, this hatchet here, this is where you're going to reconnect up here in the stomach. So you can see that here. So you've reconnected in the stomach. That's called your alimentary limb. Alimentary because it's what sees food. And then this proximal part of the stomach here needs to be reconnected, and if you can conceptualize it, that's what you're connecting here to the end of the grayed out area. So that's what you're connecting here. Why are you doing all this? Well, this is where the malabsorptive restricted component comes in. You have your stomach much smaller, so that's your restricted component. You get full faster. And then the food goes down in here, but this area here is not seeing any digestive juices. It's not going to see digestive juices until they make their way from the first part of the intestine here all the way down, and then they mix here, and you absorb the rest of the way through this. So that's how gastric bypass is done. This cartoon kind of shows that food comes in, fills up your stomach, falls through into the root limb or the alimentary limb, and then it meets digestive juices coming from your liver and pancreas here as they move down and join here, and then you can absorb the rest of the way through. So that's a gastric bypass. The duodenal switch is similar in some ways, obviously more complex as we talked about. The important thing is that you are dividing the bowel here at what's labeled B, and when you divide it there, you're going to now move it to the first part of the intestine up here, which is also divided, right? So you're going to move this distal part of B up to the first part of the intestine here where you've divided. So here's B, here's pylorus. You're going to divide just post-pyloric, and you're going to plug that into the first part of the intestine here. The part that you're left with, you're going to plug down at A. So you're plugging it here, right? So here's the common channel, right, where you've plugged this back in. And so digestive juices coming from up here will end up here, and this short segment is where you get to absorb the food you've eaten. So this is what it looks like. You've divided the intestine up here. So this is duodenum. Digestive juices go down this way. They meet here. This is your common channel, and you plug this back up to serve as your alimentary limb for food to be passed through. So this is a cartoon of that. You can see it's a sleeve gastrectomy. That's the part I had mentioned. You do a sleeve gastrectomy. You divided the duodenum. You divided the intestine down here and brought this one up here, right, to catch food. And then the biliopancreatic limb becomes really long and doesn't see any food to digest. And you attach it here, and you can see this is a little bit exaggerated, but you can see there's very little period of time where you see actual absorption of nutrients. So the good news, the lap band is 20 to 30% successful long term. 10 BMI points is typically what's called. It has the lowest risk, and that's why it was a big deal and everyone was doing it. But it also has the lowest reward when you talk about weight loss surgery, because of the success rate. The sleeve gastrectomy and bypass have almost identical results. You lose on average 15 to 20 BMI points by the first year or two. There's a higher risk associated with the gastric bypass simply because you're doing more, but it gives you better control of diabetes and treats acid reflux much better than the sleeve does. The duodenal switch is about 95% successful long term in terms of keeping the weight off. You can lose as high as 20 to 35 plus BMI points off. So you can imagine a BMI 70 person has the operation and their BMI ends up being 35 or even less. It is the highest risk operation in comparison to the other operations. So it has the highest weight loss and lowest rate of regain. So the bad news, and that's where most of this talk is focused, right? Because we like to talk about bad news for some reason. All right, so the bad news is complications, right? Early complications, mechanical complications are things like bleeding, leak, stenosis, obstruction. That's the surgeon's, I don't want to say the surgeon's fault, but that's more technical stuff. The non-mechanical stuff would be pulmonary embolism, MI, apneic arrest. So these are the big things that you should have in mind and should always be wary of. Obviously, there are other minor things, wound infection and stuff like that, but usually those aren't as big an issue. Late complications, mechanical ones, or stenosis, hernia, intussusception. Non-mechanical, things like malnutrition, vitamin deficiency, ulcers, cholelithiasis. These are the big ones, the big ones that you should be able to recognize and not miss. So in terms of early issues, bleeding, it's usually self-limiting. I always tell patients, we don't walk out of the OR with a geyser of blood squirting, right? That'd be bad form. So when you have bleeding, it's usually something small, usually. And usually that's self-limiting because the body knows how to clot that off. The signs are the typical signs you would expect from anyone bleeding: tachycardia, diaphoresis. Low blood pressure is a is a late finding. You don't want to wait till someone's bled till they're hypotensive to see that. You want to try and catch it early. The diagnosis, if it's a subtle thing, repeat CVC, and if you want to know in a hurry, a CT scan is needed. Oftentimes you see CT scans ordered quote unquote dry. That's not helpful to find out if someone's bleeding. It's not as helpful because you will see a fluid collection, but you won't know what it is. You have to give IV contrast. It makes sense. You're putting contrast in the blood circulatory system, and if it leaks out of the circulatory system, you're bleeding. So if you don't have that IV contrast, you're not going to see that well. The treatment is transfusion, and the patient should usually recover. If they don't, if they continue bleeding, then you have to look at modalities to stop that bleeding. If it's high up, you can do endoscopy to cauterize what's bleeding. If it's lower down, that's more challenging. You can go in back to the OR and sew that up. These, bleeding internally in the GI tract is unusual, and not unusual, but it's unusual that it doesn't stop on its own, because it's not typically a really dramatic bleeder.
Even with blood thinners?
Stop blood thinners for sure. That's I always forget to put that on there because it's like, it seems obvious, but a lot of times people overlook it. You have to stop the blood thinners. That's standard. And if necessary, you go back to the OR for the evacuation of the hematoma. That's excellent. In terms of early complications, the most dreaded complication is a leak, because if it's not diagnosed, it has as high as a 10% mortality rate. The incidence is 2 to 4%, depending on which study you look at. But you have to have a high index of suspicion for it. Signs could be very subtle. It could be only tachycardia. It could be diaphoresis, fever, abdominal, shoulder pain, hiccups, and low urine output. So if you see any of these things in a patient, you need to look at the patient critically and make sure that you don't feel like they're leaking. The diagnosis, upper GI can show you, CT abdomen can show you, but with the CT, you want to give PO contrast. If there's no contrast, again, you can't tell if that fluid collection is a leak or hematoma or just saline or what it is. So you want to give PO contrast. You only want to do these studies if the patient's stable. If they're not stable and you're suspecting a leak, there's nothing wrong with going back to the operator. Again, time is money. You do not want to sit on a leak hoping it's not a leak, hoping it'll go away, hoping it's just a headache, hoping. You want to be aggressive. What's scary about this is that a study looked at upper GI and CT of the abdomen in diagnosing leak, and it missed it about 20 to 30% of the time. So you could study with CT and upper GI. They could both lie to you and tell you your patient's fine as your patient continues to die. So if it ain't right, it ain't right. You need to go in and take a look. No one will ever fault you for going in and taking a look rather than hanging your hat on a CT or an upper GI. And there's lots of data that tells you that upper GI and CT are not foolproof, so you can't hold those up and say, well, I didn't know. If the patient's unstable, diagnosis not certain, then it's a trip to the operator room. The treatment, NPO, antibiotics, if the patient is clinically stable or if they have a contained leak. The treatment, if the patient's unstable or the leak's not contained, is to go to the OR for either control or repair. Now, depend on the operation. Let's say this is a gastric sleeve that has a leak, and they're stable and it's contained. Yes, you could percutaneously drain it, put a stent in. A lot of, the kind of the party line is that it all depends on the expertise you have at your facility. If you don't have a GI doctor, if you don't have stents, then you're going back to the OR to drain it. If you have radiology, they could percutate. You gotta just look at the tools you have and see the best way to address it. It's important to note that going to the OR does not mean you're gonna repair the leak. All you're trying to do is prevent the person from getting septic and dying. You can temporize the situation to let the body heal what's going on. Stenosis could be mechanical from your suture. It could be a hematoma. Gastric bypass patients can bleed right at the gastric jejunal anastomosis, and since it's so small already, a little bit of blood can clog up the whole thing and obstruct that. Signs: vomiting, dysphagia. Diagnosis: upper endoscopy or upper GI. I prefer upper endoscopy, but sometimes you can't get it done, so you do an upper GI. The problem with upper GI in the face of obstruction is now they've drank a bunch of gastrograph in, it can't go anywhere, so they're going to vomit it or it's just going to sit there. And so every night I do an upper GI and the patient is obstructed, I don't sleep because I'm waiting for the phone call that they vomited and aspirated and are now in the ICU with intubate. And it's just a nightmare scenario from that chemical pneumonitis. So if you're gonna, if you have a patient that's obstructed and they come back up after drinking gastrograph, don't let them lay flat, because that's what's gonna potentiate this aspiration problem. Upper endoscopy, you could go in. The benefit of upper endoscopy is you can diagnose and treat at the same time. If you see a hematoma, you can dislodge it. It's amazing. Even if you open up just a pinhole, the saliva can get through, and that allows the body to slowly work its way through whatever is obstructing. The treatment usually is non-operative. Usually you can wait it out and give TPN if necessary, NPO status. If it's a stricture from your suture or other things like that, if you wait long enough temporizing the patient, you can get away with, instead of doing another operation, instead you can do an upper endoscopy and dilate the area that's narrowed down. This is if your stenosis is in the upper abdomen. If it's in the lower abdomen, it's small bowel, then usually you end up with an operation, because that's usually doesn't resolve on its own, and you can't get there with endoscopy. So some of the other stuff that's not surgical per se, early complications, things like pulmonary embolus and MI. These two are things that you want to prevent rather than treat. You always want to do everything you can to prevent these two things. DVT prophylaxis is critical. You know, one of the questions that comes up is what's the appropriate DVT prophylaxis? And the short answer is who knows, right? There's nothing out there that tells you this is what you must do. I've looked at different studies. There are different studies published. The one I like the most talked about, they looked at Lovenox versus heparin and they looked at pre-op and post-op. They looked at nothing pre-op, heparin post-op, nothing pre-op, Lovenox post-op. Lovenox then heparin, heparin then Lovenox, heparin, Lovenox, Lovenox. The best outcome they saw was Lovenox. So that's what I personally do based on that study, but there's no mandatory thing. The other problem is how much do you give? Again, there's no mandatory thing. And people are moving towards giving higher doses. I do 30-30, 30 of Lovenox pre and 30 post. Some people argue you should do 40-40. Some people do as high as 60 post-op. I tried 60 for a while, I saw more bleeding. And so you do this dance between, you know, this balance of bleeding versus DVT prophylaxis, and no one has the right answer. But if you have a patient with the classical symptoms, tachycardia, tachypnea, dyspnea, you've got to think about it. It's got to be something you think about. You get that CT chest, you start anticoagulation. If you can't get a CT chest, it is not wrong to start anticoagulation empirically. There's absolutely not. If you think about it, you have a good index of suspicion, can't move the patient, and can't do it, start the anticoagulation. You know, there's a lot of argument that you shouldn't start anticoagulation within 12, 24 hours after surgery. Yes, in a perfect world, that's what you want to do. But if your patient's dead, it doesn't matter, right? And so if you need to anticoagulate, you anticoagulate, and you deal with the problems as you face them. As you can see, tachycardia comes up a lot, right? Leak tachycardia, bleeding tachycardia, PE tachycardia, right? So if they're going down for a belly CT to rule out a leak, get a chest. Get a chest, get PE off the list of things that could be going on. Because what happens is you get an abdomen CT with contrast, they come back upstairs, that's read as negative, now you're like, is it a PE? And you want to send them back down, they tell you you can't do it because they've had too much contrast. And now you're scratching your head, and now you have to anticoagulate without knowing for sure, which is not wrong. Again, do it, right? But you want to think ahead, and if you have any index of suspicion, just pan scan them. It costs the hospital money, right? So I'm always like, oh man, we're spending money here. But it'll cost you more if you miss it. It'll cost you a lot more if you miss it. And so it's better to just get it done. MI, I personally get a stress test on every patient, no matter how young or old. And I've had one patient have an MI and end up having to see their cardiologist on post-op day 3 and have stents placed in. I didn't feel too bad because he's the one that cleared her pre-op. So it's about that. You know, but the classic things, chest pain. You know, this lady, the one I'm talking about, on post-op day 1 or 2, was walking around the floor and said, boy, my chest just kind of hurts, right? The classic thing for us to do is to say, oh, here, it's just GERD. It's just this, it's just, I hate that sentence, it's not just. We've got to make sure. And the nurse taking care of this patient said, sit down, we're getting an EKG. She did it, MI, right? Imagine if she said, here's some protonics, good luck with that. God, you can only imagine what could happen next. So an EKG doesn't cost us a lot. If they have chest pain, if you're like, just not seeming right, just get it. Get it, prove that it's not happening. If the EKG is bad, cardiac enzymes, obviously the typical treatment for MI and cardiology consult. The other stuff that you want to present, apneic arrest. It's upper airway collapse, hypoventilation, patient goes into acidosis and they basically crump on you. You want to prevent this.
When we were going to reel it off.
Join us. So, you know, you want to diagnose the sleep apnea preoperatively. A lot of people get sleep studies. Patients hate it, right? They don't like doing it because it's a nuisance. But, you know, they are a high-risk group, and you want to make sure you don't miss that. I think from a hospital standpoint, the biggest thing is having patients monitored, especially when they have a history, making sure they're monitored. And, you know, you hear horror stories all the time. I always hear horror stories, and they kind of help me guide my treatment. You know, a patient on a monitor is not monitored. A patient on a monitor being monitored is monitored, right? And so you can have a patient be on monitors and nobody's paying attention, and that's how you know, all the stories I heard, a patient passed away. So people have to watch it carefully. And narcotics potentiate this. So if you have a patient with CPAP and they're like, oh, my pain's not under control, and they're getting multiple doses of narcotics, your sphincter tone's got to be so tight, making sure that patient doesn't have a problem. Stenosis, late finding, it shows up with vomiting. This is typical in gastric bypass patients, more so than sleeve, but you see it in sleeves as well. The gastrojejunal anastomosis sometimes will ulcerate, and then when it heals, it will scar down and get really tight. They'll vomit. You know, every time I hear a bariatric patient say, I vomit, but it's normal, I disagree with that. Vomiting is not normal. Even after weight loss surgery, you need an EGD to check for that. And you may need to dilate them multiple times to fix that. The reason I'm talking about this is, you know, you will have patients come to the ER and say, I'm vomiting, and people want to give Zofran and send them home. That's a wrong move. You should study that upper GI or EGD to make sure that they're not strictured down. Internal hernia, intussusception, these usually present with abdominal pain. You know, our bariatric patients a lot of times will come in complaining of abdominal pain, and we'll do everything under the sun and you won't find a reason. You keep doing it. I mean, you keep doing it because one day you're going to have an internal hernia that will die if you don't catch it, or an intussusception that will die if you don't catch it. So you have to do it. I don't even think about it. You have abdominal pain, see you in the ER. They say, oh, can I wait till, you know, next year, January, when my deductible? No, now. We do it now, we check it out. When we're done with all that, then we're okay. The last thing I'll say is on abdominal pain, intussusception, etc., is that the CT abdomen has a false negative rate. So because your CT is normal does not mean you're okay. It means it's less likely there's a problem, but does not mean you're okay. So I will do a diagnostic laparoscopy on a patient with unexplained abdominal pain. Unless we know the reason, we need to look. we need to go in and take a look. Which is very different than general surgery and some other things we do. With malnutrition, that's pretty common. I shouldn't say pretty common, but that's more likely if you've had a duodenal switch than the other operations. TPN and fixing the underlying causes is a way to treat that. I think about malnutrition is described, mild, moderate, and severe. If it's mild, usually you just need to redirect the patient and re-educate them. If it's moderate, you may need to do a course of TPN and do, what you would do for a mild. If it's severe, then with a duodenal switch, I reverse the intestinal bypass of the operation, which takes about 20 minutes to do when the patients go home the next day. It's a relatively benign operation. Vitamin deficiency is a tough one because the way they show up depends on the vitamin deficiency. I recommend that patients that come in with funny symptoms that have had a bariatric operation should get a full panel of vitamins. Because if you're not thinking about it, you won't do it. If you're scratching your head saying, this doesn't make sense, just get it. Get the set of labs, make sure everything's okay. Depending on the vitamin, they may come in with ulcers on their tongue. You would not associate ulcers on the tongue with weight loss surgery, but it is. They may come in confused. They may come in just forgetful. They may come in just weird. That's a classic sign that I need to check all their vitamins. And then you replete those vitamins as necessary. Gastrointestinal ulcers, ulcers in general, these are your smokers or people that take NSAIDs. I've gotten used to reading past medical history, and if I see arthritis, right, and weight loss surgery, I assume they're taking an NSAID. And so you want to evaluate that again with upper endoscopy. The treatment's usually carotid connection and avoid the offending agent. Cholelithiasis, relatively straightforward, mid-epigastric right upper quadrant abdominal pain, ultrasound, and removal of gallbladder. And then the last one is weight regain, and what do you do? So I have a pretty liberal approach to weight loss surgery. I equate morbid obesity a lot to diabetes. I think it's a disease process we don't fully understand. We don't know what causes it. Everyone has their idea, but we're not clear on what does it. And I approach it the same way you approach diabetes, where we were talking about this earlier, that eating sugar does not make you a diabetic. But once you are diabetic, you gotta watch your sugar intake. Eating food doesn't necessarily make you morbidly obese, but once you are, you've got to watch your diet. People say, well, it's eating too fast, and they say, when you watch eating contests, and these guys are chucking down hot dogs, well, they're eating fast, and they're eating a lot, and they're all like this, right? So it flies in the face of a lot of things we know, but once you are morbidly obese, now you need to watch your diet more so than someone that is not, because we all know that disgusting person that doesn't gain any weight even though they eat whatever they want, right? So with diabetes, when people show up and they're diabetic and you change their lifestyle and they come back, their blood sugar is still high, you don't ask them, did you lick one single ice cream? And if you did, then get out of my office, I never want to see you again. If their blood sugar is still high, lifestyle changes didn't work, you start them on metformin. They come back still high, you start them on insulin. If they come back still high, you go up on the insulin. You put them on an insulin drip. You escalate therapy. The same thing with obesity. You've got to escalate therapy. Yes, you want to tell that person, watch your sugar, etc., but you still escalate therapy. So same thing with weight regain in my opinion, right? If you've had a band and you've regained, we can talk about conversion to any of the operations. If you've had a sleeve, we can look at a bypass versus a DS. If you've had a bypass, your options are less so. A DS. If you've had a DS, there's really no good surgical option. Thankfully, it occurs rarely. But if you've had a DS and you have weight regain, then you got to go back to the broad picture. There are only 3 ways to lose weight. There are lifestyle changes, diet and exercise, weight loss drug, and weight loss surgery. That's it. There's nothing else. Again, please, my number is 940-387. Come up with an idea, you call me first, okay? So then we add a weight loss drug. The last thing I would say about weight regaining is a lot of times it's better not to wait till people regain weight. If I do a sleeve gastrectomy and 3-6 months later the patient's not losing weight like we want them to, we expect them to, we add a weight loss drug before they have problems. It's interesting because 3 or 4 years ago I was at ASMBS and they were talking about weight regain. And one of the psych doctors in internal medicine guy goes up and he says, if a patient regains weight, I don't think they should have anything else done. And everybody stood up and clapped. Now I sat down. because I thought that was the most ridiculous thing I've ever heard. You have to treat obesity aggressively and vigilantly. And people are not all going to respond the same way because we're not all built the same. This year, there was a study saying, don't wait till people regain weight to add stuff. Don't wait till they regain to add the cuisine, or the country or the phentermine and so on and so forth. And it's hard, it's nice to see that it's being taken a lot more seriously and people are treating it more aggressively. That's all I've got prepared. So now we can just answer questions and talk about some of the other stuff you guys want to talk about.
Do you ever send anybody home on Lovenox?
Yes, BMI over 55. Which goes back to, my point earlier, there's no rule.
There's no recommendation,
There's no
no
rule.
standard, no.
No standards. If I operate on a guy that was in a wheelchair, quadriplegic, and he wanted a DS, I said no, because I was worried he wouldn't be able to change himself and he may get ulcers and stuff like that. So I said bypass. I told him, because you're non-ambulatory, you're going home on Lovenox. His BMI was 35, 36. So it's more looking at the whole scenario and saying, it's risk management. You have a patient that says, I live in Alaska. I'm going to come down, do surgery, but I'm flying out the next day. You're getting Lovenox. Because that long flight bumps up your risk.
Right.
And I explain this to patients. This is a risk game. And for everything you do that bumps up your risk, I've got to do something to push it back down. And so a higher BMI pushes your risk up. And then the question becomes how much? I had a lady that had a history of DVT, so I sent her home on Lovenox. She got a blood clot. Right? And in retrospect, we should have probably anticoagulated her. So it's different when you're just doing it prophylactically and when you're actually anticoagulating. So that might be someone that should have gone home on Coumadin, for example. So if she were ever have surgery with me again, I would heparinize her, I would anticoagulate her fully. But in general, if your BMI is above 55, then I'll do it routinely. If you're traveling, if your mobility is limited, if I see that when we ask you to walk the pods, you do half a pod, and your family's there ribbing you to do it, you're going home on Lovenox, because you're not going to do it at home when the nurses aren't harassing you, and your family's going to go to work. And so I know you're going to be on the couch more so than another patient. So I'd send you home on Lovenox if you're kind of fuming. So it's a judgment call of what the risk looks like. What else you got?
A lot of times you said abdominal pain or shoulder pain.
Mm-hmm.
A lot of that is gas too, so how do we differentiate between what's serious and what's just the gas pain?
Good question. There are a few things that will cause shoulder pain. Gas, as you said, JP drains will do it. A JP drain sitting up on the left side will give shoulder pain. A hematoma will do it. Different things will do it. You have to marry the whole thing. There are patients you walk in their room and they look lovely. The eyeball test, you walk in and man, this patient just looks great. And they say, oh man, I guess I'm shoulder pain, but they're walking in the house, they're doing well. Y counts normal or trending down. Okay, you can watch that. They're not tachycardic. But a patient that says, oh, I got shoulder pain and their heart rate stays at 115. Don't call that gas pain. If you're worried, a lot of these are with bariatrics, a lot of them are just judgment calls. And it just depends on what side you want to err on. And my perspective is to err on overdoing rather than under. So look at everything else. Look at everything else. What's the Y count doing? What's the heart rate doing? How does the patient look? How's their belly exam? What's the JP drain look like? And if you have enough of these things that tell you, boy, this just isn't right, study them. Study them and then watch their progression. If the drain comes out and they're still having shoulder pain, if it's day 2, they're still having shoulder pain, scan them. Oral contrast, IV contrast, scan them, see what's going on. Because the sooner you do that, the quicker you can move on to say, okay, that's okay. If they're in PACU with shoulder pain, that's probably not a leak. That's a little bit too early for something to show itself. If they came up with shoulder pain from PACU, that's probably gas. If the next morning their shoulder pain's worse and they're starting to get tacky and their white count instead of being 13 is 21, calm. that may even be a trip to the OR just to kick the tires and make sure everything's okay. But if they come up shoulder pain and then 5 hours later it's a little bit better, okay, that's your CO2 gas. That's my short answer.
What's the ER? So, the leaks, is it more common for those to happen after they come home, like
Yeah.
a week, 2 weeks,
Yeah.
3 weeks?
Yeah.
They're gonna be here?
Yeah. So you can, well, I didn't define late and early, but early is still like 6 weeks out.
Okay.
Bleed 24 hours usually. If they don't bleed within the first 24, that's why I keep virtually all my patients overnight. Sorry, Myra. Okay. If a bleed's gonna happen, it's gonna happen within 24 hours. As a general surgery resident, I had a friend, and this is really a friend, not me. Okay, I had a friend. Right, yeah, a friend. This is really not me. But I heard a story of a patient, 20-something-year-old girl, had a gallbladder removed. Was kind of lethargic a little bit in the PACU, but they thought she was just tired, and they sent her home. All gallbladders go, they sent her home. She got home, was still lethargic, said she was going to go take a nap, went upstairs. That was the last anyone saw her alive. 20-something-year-old, bothers me. I still know that, that story well. So I'm always worried of trusting patient, family to take a patient home that shows you signs, but they just don't know. My nursing staff, they know. They know if a patient is looking wrong to at least call somebody. A blood transfusion would have changed that family's life. And so that's why I lean towards watching that 23-hour obs. If I do a sleep early in the morning, and by the evening they look fantastic and everything's good, fine. But if they're not right, just watch them overnight, make sure that nothing happens. So a bleed, 24 hours. A leak can happen up to 6 weeks. I've seen it, The good news though is that the further out they leak, the less bad it is, right? The further out they leak, the safer that leak is, the easier it is to manage, so to speak. It's kind of like bleeding. A slow, gradual bleed is, a person could bleed out to a hemoglobin of 6 if they do it slowly enough so the body can compensate. A rapid drop is what kills you. So usually the folks that leak later on will not need any surgical intervention. Usually you just TPN and let it, antibiotics and let it heal. It's the immediate ones that do you harm. And so that's why I stress more the in-hospital leak. But at the same time, when patients show up in the ER with vague GI complaints, you have to scan them and look for a problem, even if you have not find one.
Can the leak happen anywhere along like the suture line or the staple line?
Yeah,
Or
so
certain places it usually happen.
So, I talked about the difference between stapling and non-stapling. And so with this, there's no word per se to leak. With this, you can leak anywhere on this staple line. The most likely places to leak are up here. And the reason why you leak up here is that you notice here the stomach's big and here it's big. And then it gets narrow and then it gets big again. So the narrowest part there, if you're too greedy with your sleeve, you can basically kink that off and you have pressure and it blows out here like a tire. So that's where you usually see a leak, but you could get one anywhere up and down this. Patients that are having revisional surgery, if there's foreign body there, that doesn't let it heal, you can have a leak there. With a bypass, you're gonna most likely see a leak here, the gastroduodenal anastomosis. This lower anastomosis of the small bowel tends not to leak. It's such a low pressure system that the tendency is just overwhelming for it not to leak. The bad news is if it does leak, it's very hard to identify. Very difficult, because by the time your contrast gets down there, it's diluted, and again, it's not high pressure, so you don't see it. Usually it's going to be here, the GJ. The good news is that you can reach that endoscopically, you can just put a stent around it. With a duodenal switch, interestingly enough, the highest risk is here, your sleeve staple one, for the same reason. Next up is here, this duodenal anastomosis. This lower one rarely, if ever, leaks. The one that's scariest is your duodenal stump here. If it blows out, that's actually a big mess because you can't get to it endoscopically to identify contrast will never get there, ever. And so all you see on CT scan is fluid here, but that's where you're divided. So is that a hematoma? Is that, what is that? Right, so you see fluid sitting there. It's a very difficult diagnosis to make. And, the good news is, if you are suspicious enough and you treat with antibiotics and put a drain there, the patient will do fine and they'll do that. One of the other things I like to point out is this, with these two operations, the Roux-en-Y and the DS. If you obstruct here, right? If you obstruct right here, will an NG tube help you? No, absolutely not. Conservative therapy won't help you. This is a closed loop obstruction. They're closed up here, and if you go all the way back, they're closed up here. And the liver and pancreas don't care. They're gonna continue pumping juices and fluid into this closed system. What's gonna happen? You're gonna stretch it out, you're gonna blow it out. That's the scariest thing, is when you have that kind of thing. So when you see the ER gets a CT and a general surgeon or someone that's just unfamiliar says, oh, it's a bowel obstruction, put an NG tube down, we'll watch him overnight. No, that's a surgical emergency. That's a closed loop obstruction that you need to get in immediately. Same thing here. If you obstruct here, NG tube's not going to help you. There's no way you're going to decompress that without an operation. And one of the ways you can tell that that's what you have is that this obstruction here forces everything to back up. Some's going to back up to the stomach, but when it has nowhere else to go, it's going to go up the biliary tree into the liver, and your liver enzymes will shoot up, your pancreatic enzymes will shoot up. And so if you see LFTs significantly elevated in a bariatric patient with a CT showing obstruction, that, even without the CT, that should tip you off that they may have obstruction of the biliary pancreatic limb. Now, if you have obstruction in this limb here, they'll vomit, and if you have it even down here, it will preferentially go where it can get out, and they'll vomit. And an NG tube can help you there, but you shouldn't rest on the NG tube.
So on the DSs, did we decide to do swallows post-op day 2? Or?
So I'll tell you why I did swallows here early on, is that one, I was new at the facility, and two, I didn't know when radiology could be here. So the last call I want is, it's, I don't know, 7 p.m. Dr. Ayoola, your patient's a little bit tachycardic. And now you gotta get an upper GI. Well, radiology doesn't come. Now you gotta operate on it. And so if you have an upper GI in the morning, at least you have a little bit more sense. Again, you can't really hang your hat on the EGD and so on. So I think if your nursing staff is paranoid enough where they're just like, if a patient don't look right, you're gonna know about it, then you don't need the upper GI. But
With the DSs, that's why we like to do them, I'm the radiology director, post-op day 2, because that distal anastomosis, sometimes it takes hours to get down there just because the bowels are still,
so slow.
yeah,
I agree.
and so that's why
I don't do it. I'll tell you, I don't do an upper GI everywhere. So it's not like something I do standard for every single patient. I will do them standard on revisions because they have such a higher rate of bleed. And I'll tell you that the anastomosis I'm worried about is your DI. Yeah, if you show me DI is okay, and obviously the sleeve stable line is okay. I don't normally do assault on my sleeves at all. But if I just want to look at the proximal stuff. I don't mind if we don't evaluate this.
Okay.
Because it's so rare.
Well, that helps too.
Anything else? Go once? All right, well, thank y'all.
Thank
you.